I call upon the first speaker on Harmandeep Singh on polyostotic craniofacial fibrous dysplasia with a bilateral optic nerve compression. Is here?
Yes, sir. Good morning, everyone. I'm Dr. Harman, second year postgraduate student from MGM Medical College, and I'll be presenting a case of polyostotic craniofacial fibrous dysplasia with bilateral optic nerve compression. So, a 19-year-old male presented with no vision in left eye for 6 years and mild blurring of vision in right eye for 1 year. On gross examination, I noticed a left-sided frontal bulge, and the left eyeball was proptosed and inferiorly displaced. The visual acuity in the right eye was 618, and in the left eye, patient had no perception of light. On slit lamp examination, the significant findings in the right eye was central nebular opacity in the cornea, and in the left eye, the patient had an RAPD and a traumatic cataract. Rest examination anterior segment was within normal limits. Axial length of the eyeballs is as follows: 22.5 for the right eye and 21.9 for the left. The pictures show the central nebular opacity in the right eye, and the posterior segment of the right eye was well within normal limits. This picture shows the traumatic cataract due to a blunt trauma sustained in the left eye 3 years ago, as stated by the patient. A manual SICS was done in the left eye for cosmetic reasons because the patient wanted a black pupil, and the cataractus lens was removed along with the adherent and wrinkled capsule, and the eye was left aphakic. The post-op fundus examination of the left eye revealed an optic disc pallor and severely attenuated vessels and diffusely thinned out retina with multiple atrophic patches, and we can see the sclera shining through the atrophic patches, atrophic choroid and retina. A CT head was ordered, which shows mixed sclerotic and lytic intraosseous lesions, showing ground glass appearance. In the figure A, we can see the lesion in the left frontal bone. In the figure B, we can see the lesion in the ethmoidal sinuses and the greater wing of sphenoid, thus affecting the medial and lateral orbital walls on the left side. And in the figure C, we can see a reduction in the size of the maxillary sinus. The lesion was also extending into the pterygoid, causing ballooning of the pterygoid plate on the left side and also the left hemimandible. Figure A shows the left pterygoid plate affected, and the figure B shows the left hemimandible affected. MRI brain and orbit showed near complete obliteration of the left optic canal on the left optic canal, and the left optic nerve was severely compressed. Due to the chronic compression, left optic nerve atrophy was observed. We can see in the figure B the left optic nerve is pretty compressed, and in the figure A we can see the mass effect on the brain parenchyma on the left side, but there is no midline shift of the structures. There was also mild narrowing of the right optic canal along with mild tortuosity of the optic nerve course. And the optic canal transverse diameters were as follows. So on the right side it was 3.5 mm, and on the left side it was 2.5 mm. The normal value is 3.6 mm. So my differentials were fibrous dysplasia of the craniofacial variety, McCune-Albright syndrome, Paget's disease, cherubism, and focal cemento-osseous dysplasia. The additional investigations done were hearing assessment using pure tone audiometry was within normal limits, so the 8th nerve was not affected. Alkaline phosphatase was within normal limits, ruling out Paget's disease. There was no history of any bone pain or fracture. There were no cafe au lait spots, and there were no endocrinopathies, as all the hormone levels were normal, ruling out McCune-Albright syndrome. There was no Shepherd's hook deformity seen on X-ray of the hip joint, which is actually a characteristic of fibrous dysplasia. So my diagnosis, according to the radiological and clinical findings, comes down to polyostotic craniofacial fibrous dysplasia with bilateral optic nerve compression. For the treatment, we got a neurosurgeon consult, and the patient was advised to be on 3 monthly follow-up to monitor for worsening of the disease, which would be indicated by worsening of vision or visual field in the right eye. Prophylactic decompression surgery is not advised as a primary surgical procedure due to complications of the procedure itself, and also the disease tends to flare in puberty and dies down after puberty. So, fibrous dysplasia is basically a disease where the normal bone is replaced by immature fibroosseous tissue, which is softer and weaker than normal, and it usually affects the long bones, ribs, craniofacial bones, and pelvis. When accompanied by endocrinopathies and cafe au lait spots, it is called McCune-Albright syndrome. And craniofacial involvement is seen in 20% of the cases, and it may be monostotic or polyostotic. The most catastrophic complication is optic nerve compression, and the patient can present with diminished color vision, restricted visual fields, and visual acuity. These are my references. Thank you.
Nice presentation. You have very good images, and you have also masked the patient identity. That is good. You can also label them.
Yes, sir.
That would be even good.
Yes, sir.
So, what was the advice given to the patient?
Sir, so the disease presents in childhood, and it progresses in puberty and then dies down after puberty. So we have put the patient on 3 monthly follow-up to monitor if there is any worsening in the right eye vision, or there is any radiological worsening of the disease on the right side, so that because if more optic canal compression is detected, we will have to go for therapeutic decompression surgery.
And just one point is you would also have to monitor the visual fields.
Yes, sir.
That would be much easier to do than the repeat imaging.
Yes, sir.
What is the chance of getting the right eye involvement as per the literature you have searched? It is not a unique entity to everybody.
Yes,
it
sir.
is unique for that patient.
Yes,
it
sir.
is variable. And in that also, what is the chance of getting the other eye involvement in the literature?
Sir, according to the literature, I have seen there were no involvement of the other side. It was just unilateral in all the literature studied. Thank you, sir. Thank you, everyone.
So next we invite Dr. G. Sarmada for presenting on role of OCT in management of benign intracranial hypertension.
Good morning, everyone. Today my topic of presentation is role of OCT in management of benign intracranial hypertension. No financial disclosure. Introduction: bilateral optic disc swelling due to increased intracranial pressure with a negative neuroimaging and normal visual acuity and visual field showing enlarged blind spot is diagnosed as a case of benign intracranial hypertension. From the fundus pictures we can see there is bilateral disc swelling. Aim of the study: to study the OCT, ONH and RNFN analysis and GCA in patients of benign intracranial hypertension, to follow up the response to treatment by serial RNFL and GCA scans. Methods and materials: prospective study with sample size 10 who attended a tertiary eye care center on outpatient basis from October 2022 to June 2023. Benign intracranial hypertension cases were followed up with OCT, ONH, RNFL and GCA to determine the response or failure to the medical or surgical management. Here we can see OCT printout analysis in disc edema. Mainly we have to see for neuroretinal rim thickness increase and RNFL thickness increase, and here we can see the RNFL clockers also are showing disc edema, and in GCA, in cases of chronic papillary edema who were not treated on time, they will be resulting in optic atrophy, which can be seen on GCA scans. As coming to the cases, this patient presented to us with raised intracranial symptoms findings, and her BP was normal, and her anterior segment was normal, and posterior segment showed bilateral disc swelling, and her neuroimaging was negative, and optic OCT is showing both RNFL thickness is increased, and on treatment with acetazolamide 250 milligrams QID for 2 months, her disc edema was resolved and her disc remained normal. Coming to the second case, her patient anterior segment was normal. She also presented with raised intracranial signs and symptoms presentation. On taking OCT, RNFL showed higher values, nearly it is approaching 606, and we started the patient on acetazolamide and sent for neuroimaging, which was suggestive of BH, and we immediately referred the patient to neurologist for the opinion on shunt, and her shunt procedure was delayed. This resulted in starting of optic atrophy, and later it was much delayed and patient went into severe convulsions, and later surgery was done. Due to the delayed shunt procedure, secondary optic atrophy ensued in this patient, which can be seen in the fundus and also represented in the GCA. Coming to the third case, this patient is a pregnant female who presented us with bilateral disc edema. She was started on acetazolamide 250 milligrams QID and was taken gynec opinion. MTP was done in this case after usage of Dimox for 2 months. Her disc edema was reduced and GCA was normal. Again she became pregnant and again her disc edema started. She had to undergo MTP, then only her disc edema was subsided. These are the 10 cases before medical management, and this one case which we had given shunt procedure, this case is highlighted here. Coming to the discussion, in optic nerve head analysis, we first sought to measure whole of the neuroretinal rim thickness, but it was difficult to quantify. Then we observed that RNFL thickness was more reliable in assessment of disc edema quantitatively in cases of BIH. Disc edema is only confined to RNFL thickness. In chronic BIH, decrease in GCA is indicative of optic atrophy. OCT, ONH and RNFL and GCA analysis helps us in diagnosing of papilledema or BIH. Following up of these cases, whether to refer the patient for a shunt procedure, post shunt to assess the thickness of GCA. From our study, we like to propose that OCT is better adjoint than visual fields in monitoring or management of BIH. Results showed one patient had increased in RNFL thickness in spite of maximum medical therapy, 2 patients had to restart, and rest 7 patients had stable RNFL on medical management. Drawback of the study is this is a small sample size. So conclusion is OCT is non-invasive, patient independent and primary modality in diagnosis, treatment and prognostication of benign intracranial hypertension. OCT, ONH, RNFL and GCA can completely replace the visual fields in evaluation and management of papilledema. These are my references. Thank you.
Well documented case, but what is your take home message of the second case?
So in that case, actually we had to monitor the RNFL thickness and while monitoring the RNFL thickness in the second visit when she came, her RNFL thickness was decreasing, and immediately we saw that there is signs of optic atrophy. So immediately this patient could have we could have saved her eye when correctly she would have gone for shunt procedure in time, then we could have saved her eye.
Take home message. Early treatment is most important.
Yes.
Starting on a drugs. What are the drugs they are used to start?
So we started on acetazolamide 250 milligrams QID, and with that syrup potassium supplementation should be given.
So we can't take it granted these things going to subside. We have to be very, very cautious, inform the patient, otherwise they become blind. So this is what is the most important
Yes, sir.
thing. We can't take it granted. These things will subside by giving one tablet. You have to closely follow it up.
See that we cannot conclude that OCT can replace.
Okay, sir.
You have not done any comparative study to tell anything, and the role is supplementary. So let us not go back with that conclusion. The number 2 thing is that what is most important is that while the RNFL thickness might remain high, the person will first start losing ganglion cells, so your macular GCL levels will start going to deteriorate. In a monitoring of papilledema, always a person has to look at both RNFL as well as MGCL thickness, and MGCL thickness can be RNSL down. So you have to do a separate segmentation in papilledema.
Okay, sir.
So with this you can use. Okay, so it's an important message, but it should be taken with caution with what you have concluded.
Okay, sir. Okay, thank you, sir.
Actually, what sir said is very important. Visual fields are more first line of diagnosing a case of this benign placed intracranial.
Sir, actually.
No, actually, it is a supplement.
Yeah, okay.
That's it.
Any studies done on this OCT in early diagnosis of papilledema? The papilledema is very subtle, it's very difficult to diagnose whether it's there or not. Does OCT help in that kind of a case?
Yeah,
case
yes, sir.
scenario?
We had one case in our presentation, like it showed only unilateral papilledema on fundus examination. While we did OCT, it showed RNFL thickness in OCT. That fundus was normal in that case. By that we could have diagnosed that case as BIH.
Okay, thank you.
There are special techniques also in OCT that can be utilized. So maybe in the interest of time we'll move ahead, but there are different technologies in OCT only that can be utilized.
Okay, sir. Thank you, sir. Can we leave, sir?
So we call the third speaker by Dr. Soumya Shri Samal, an unusual presentation of craniopharyngioma.
Good morning, everyone. I, Dr. Someshri Samal. I'm going to present a case of an unusual presentation of craniopharyngioma, no financial disclosure. So, my patient, 22-year-old male from Kendrapada, Odisha, came with a complaint of diminution of vision in both eyes, left more than right, for the past 5 years, which got worsened over the last 20 days. It was associated with intermittent headache and vomiting. Proper history and detailed examination revealed features of hypogonadotrophic hypogonadism with hyposmia, growth retardation and delayed puberty. BMI was 17.9. On ocular examination, right eye best corrected visual acuity was 6 by 24 parts. Left eye BCVA was hand movement positive. Color vision contrast sensitivity was not assessed. There was mild to moderate ptosis. Pupil showed grade 2 RAPD. On strabismus workup, Hirschberg corneal reflex test showed 7-degree left exotropia, modified Krimsky's test showed 12 prism diopter left exotropia. Fundus finding of both eye showed diffuse disc pallor. HVF finding 24-2 of right eye showed temporal hemianopia. Left eye was not assessed due to low vision. So interpretation was presumed junctional scotoma. Then we came to a provisional diagnosis of both eye optic atrophy with left eye mild to moderate ptosis, sensory exotropia with presumed junctional scotoma to rule out chiasmal compression, cellar or supracellular or infracellular lesion, Kalman syndrome to rule out. Then we went for neuroimaging and laboratory workup. Medicine and ENT consultation was done to confirm diagnosis of Kalman syndrome. Contrast enhanced MRI brain and orbit showed large lobulated peripherally enhancing cystic lesion involving the cellar and supracellular region, iso to hypointense on T1 and hyperintense on T2 and flare sequences, with heterogeneous post-contrast enhancement compressing the optic chiasm and tract and protruding into the third ventricle suggestive of craniopharyngioma. Laboratory investigation showed increased level of prolactin, decreased serum TSH, FSH, LH, IGF-1 and growth hormone. Then with the following neuroimaging and laboratory workup, we came to a final diagnosis of both eye optic atrophy with left eye mild to moderate ptosis, sensory exotropia with presumed junctional scotoma suggestive of craniopharyngioma, hyposmia with hypogonadotrophic hypogonadism in Kalman syndrome. He underwent right perional craniotomy with subtotal decompression of the tumor. Specimen was sent for biopsy, showed adamantinomatous craniopharyngioma. Then he was prescribed hormone replacement therapy and adjuvant radiotherapy. Craniopharyngioma is the third most common intracranial tumor of the childhood and adolescence. Presenting features are diminution of vision, headache, nausea, vomiting, bitemporal hemianopia. Adamantinomatous subtype is the most commonly found in the pediatric age group. Compression of the neurovascular structure can lead to endocrine disorder, visual loss, and then raised intracranial pressure. Hypopituitarism leading to delayed puberty is a very rare manifestation of craniopharyngioma. Hormonal assay can very rarely reveal deficiency of growth hormone, follicle stimulating hormone, and luteinizing hormone, resulting in growth failure and delayed puberty. Kalman syndrome is a congenital form of hypogonadotrophic hypogonadism that manifests with hypoanosmia. It affects 1 in 48,000 individuals. There is failure in differentiation or migration of the neuron that arise embryonologically in the olfactory mucosa. Association of craniopharyngioma with Kalman syndrome is a very rarely reported entity. Delayed puberty and hypogonadotrophic hypogonadism along with stunted growth in our patient could be because of combined effect of craniopharyngioma and Kalman syndrome. Uniqueness in our case is delayed puberty and features of hypogonadotrophic hypogonadism along with hyposmia and stunted growth in patient with craniopharyngioma. Co-presence of Kalman syndrome is an incidental diagnosis, very rarely reported entity. So role of ophthalmologist in meticulous history taking, thorough systemic examination along with ocular examination signifies evaluate the patient as a whole, not the eyes only. So my take-home message will be in patient presenting with signs of hypopituitarism, including delayed puberty and short stature, craniopharyngioma should be suspected when diagnosing tumor in cellar or supracellular region. Craniopharyngioma are typically accompanied by neuroendocrine dysfunction. Their proximity to vital neurovascular structure most commonly indicates microsurgical intervention. Features of hyposmia along with hypogonadotrophic hypogonadism in addition to hypopituitarism can lead to high suspicion of co-presence of Kalman syndrome in patient with craniopharyngioma. Though the simultaneous presence of these two disease entity in the same individual is a coincidental finding, thorough systemic evaluation and proper laboratory investigation help us in arriving at the correct diagnosis. These are my references. Thank you.
well-documented case, and one should always remember these cases.
Yes, sir.
Even if they're mild pallor with the hormonal changes, one should suspect some problem in the brain,
Yes, sir.
hypophyseal region. One should have a good MRI,
MRI, yes,
because
sir.
this case has almost involved the third ventricle.
Yes,
So
sir.
naturally, now concentration is only on the survival of the patient.
Yeah.
So they require a good neurosurgery.
Yes.
Then only they survive. Otherwise, their life will be at danger.
Yes, sir.
So that is what the role of an ophthalmologist, to identify early any pallor, any other changes. Immediately you think of the intracranial problem, not just because some glaucoma. There are patients. There are patients I have seen.
Know whether they are secretory or non-secretory just by imaging. We need to do an endocrine evaluation for all. And you can also always hide the patient name and other details in the images. Thank you.
Thank you, sir.
We're going on. We're going on to the next one. Is lactation optic neuritis by clinical profile and outcomes by, what is his name? Abhisha Sharma.
Good morning, everyone. I am Abhipsa Sharma, and I'll be presenting my study on lactation optic neuritis, the clinical profile and outcomes. These are the abbreviations used in my presentation. The clinical course of lactation optic neuritis is almost similar to classic optic neuritis, and the proposed pathogenesis includes T helper type 1 and type 2 cytokine imbalances and a sudden drop in estrogen, progesterone, and glucocorticoid levels after pregnancy. According to the literature, 1/3 of women with existing disease will have an exacerbation during the purpurium, and it occurs mostly within 3 months post-delivery. And when we were reviewing the literature, we found that there are only case reports which tell about the optic neuritis during the lactation period, and mostly they show a MS exacerbation. And there are other studies also which are not about optic neuritis but about the other manifestations of the disease in neuromyelitis optica spectrum disorders, and they also say that there is a possible exacerbation or a relapse after pregnancy when the breastfeeding starts. So there was a paucity of data on optic neuritis in lactation, and only case reports were available in the literature, and there were paucity of guidelines on treatment of optic neuritis during lactation. The purpose of this study was to describe the demographic characteristics, etiology, visual outcomes, clinical radiological outcomes of lactation optic neuritis. We did a retrospective analysis of patients presenting to the neuro-ophthalmology OPD with optic neuritis during lactation period, and we excluded any other causes of optic neuropathy in these patients and any other coexisting cause of subnormal vision. The age, clinical presentation, laterality, visual acuity, radiological changes, optic dysmorphology, and the treatment, including immunosuppressants, was studied at presentation and at follow-up. A total of 38 eyes of 25 patients met the criteria. The study period was from January 2016 to June 2022. We found a prevalence of 2.23% among all the females with optic neuritis, and the mean age was 22.48 years. The follow-up was a median of 6 months. 13 patients presented as a bilateral involvement and 12 presented as a unilateral involvement. It was a first episode in 22 patients and a reoccurrence in 3 patients. 75% of the patients, they presented within 3 months postpartum, and the data was available for 22 patients out of the 25 patients. The patients had an ocular pain in 11 cases, a headache associated in 7 cases, limb weakness in 3, and ataxia in 1. The visual acuity continued to improve over till the final follow-up, as did the HVF mean deviation, and the most common field effect at presentation was a total field effect followed by a central scotoma, and the most common field defect at 6 months was a central scotoma. The optic disc morphology had, amongst all the 38 eyes, 58% had papillitis and 36% had an optic disc pallor at presentation, and at follow-up, 91% of the eyes had an optic disc pallor. 15 of the 25 patients were tested for NMO-MOG with the one patient was found to be seropositive for NMO, and 2 patients were found to be seropositive for MOG. One patient had a history of COVID vaccination 4 months before the attack, and 1 person had a history of PIH in all pregnancies, and 1 patient had a history of gestational diabetes mellitus. Coming to the radiological findings amongst the optic nerve, 2 patients had a short segment involvement, 9 a long segment involvement, 8 a long segment and posterior optic nerve involvement, 5 patients had chiasm involvement along with long segment, and 1 patient had a posterior optic nerve involvement. So MRI spine was done in 4 patients only, and in 1 patient with MOG optic neuritis, there were T2 hyperintense lesions from D9 to D12 level. The patients were treated with IV methylprednisolone, either a 3-day or a 5-day course, and it was followed by a course of oral steroids and tapering doses. 2 patients were put on azathioprine, which were proven NMO and proven MOG, and 1 patient was started with rituximab. 3 patients had a reoccurrence on treatment, 1 had bilateral involvement and 2 had a unilateral involvement. The common finding amongst these were that there was a poor visual acuity at presentation, long segment involvement and a chiasm involvement. Involved disc had papillitis. They had relapsed after oral steroids were stopped, and all were seronegative for NMO or MOG. None had brain involvement or neurological symptoms. It was a retrospective study, small sample size, serology was not done for all cases, and there was a non-uniform data documentation and a short follow-up. In conclusion, this is an uncommon entity. It occurs mostly in first 3 months after delivery, and most patients had a typical optic neuritis. 3 had atypical optic neuritis. Radiological features, mainly optic nerve involvement was there, and the pattern was radiologically similar to MOG, and none had MS-like lesions. There was no treatment change, but there was an alteration with the feeding time. It's not a separate disease, but it's more likely to be reactivation of the immune system. Thank you.
Well-documented cases, and I have a very interesting question. What is the reason you have put the title as a lactation optic neuritis? Any reason for that? Actually, optic neuritis during lactation. There is no cause and effect.
Yes.
So the title also gives you some sort of inference. Whenever you are putting a title, you should be able to give an inference to the reader that this is what we are going to see. It giving me as a
we'll change.
Lactation is responsible for no, it is not.
Okay.
So what? Any reason you have put that?
No.
Yeah, the only reason is that there is a concept going around even in the neuro-ophthalmology circle that optic neuritis during lactation is a separate entity, and they have described it as a lactation optic neuritis in the past literature. So
any reason for that?
There is a possibly that's what was the purpose of studying, that is it a separate disease or is it the recurrence of the same immunological disease that could be happening. So that was our observation. We wanted to disprove that. That's why we kept it.
What usually says in the literature is there is an immune status is altered during the lactation period. Those who are vulnerable for demyelinating diseases, they are more vulnerable to manifest. That is the one reason. This is the period where vulnerability is high. So that has to be remembered. So one should be always able to cautiously evaluate these patients whenever they are postpartum patients.
Fully agree with you, but we wanted to disprove what is there in the case reports. That's why we worked on this study. Thank you. Yes, there are case reports which are published with that title.
Thank you.
So coming to the next generation presentation, Dr. Sonalika on orbital apex syndrome, clinico-etiological profile, diagnostic challenges and outcomes.
Good afternoon, everyone. So I'll be talking about our study title, orbital apex syndrome, the clinico-etiological profile, diagnostic challenges and outcomes. So, orbital apex syndrome, it refers to a constellation of symptoms and signs which results from the involvement of various structures in the region of orbital apex by a disease process. And it is characterized by ophthalmoplegia, proptosis, and ptosis from palsy of cranial nerves, 3rd, 4th, and 6th, hypoesthesia of ipsilateral forehead, upper eyelid, and cornea by involvement of the ophthalmic division of the trigeminal nerve, and eventual visual deficit from optic neuropathy. So the objective of my study was to report the clinical profile, diagnostic challenges, and outcomes in cases of orbital apex syndrome presenting to neuro-ophthalmologists or neurologists. So we did a retrospective review of records of patients with neuroimaging proven orbital apex syndrome seen from October 1, 2018 to June 30, 2022. We documented the age and gender, the clinical presentation, visual acuity, visual fields, radiological changes, optic disc morphology, and the treatment given at presentation and follow-up. So the MRI brain findings were characterized as following, suggestive of either a granulomatous lesion, a fungal etiology, IgG4 disease, MOG optic neuritis, carotid cavernous fistula or cavernous sinus thrombosis, cysticercosis, neoplasm, non-specific inflammation, and if there was no abnormality recorded. So the patients underwent MAN2 test, chest X-ray, serum ACE levels, IgG4 levels in blood, ANA profile with ANCA and endoscopy, biopsy, thyroid profile, and CSF analysis. And a total of 52 patients with orbital apex syndrome were identified with a female preponderance. The median age was 46.5 years, and the median follow-up duration was 3.5 months. And 22 patients had hypertension as the associated comorbidity, 20 patients with diabetes mellitus, and 10 patients had a history of COVID infection, and 2 patients had dyslipidemia, and 2 underwent ENT procedures. And the presenting complaints, the major presenting complaint was blurred vision in 40 patients, periocular pain in 30 patients, ptosis in 30 patients, diplopia in 16 patients, and proptosis in 14 patients. And 47 out of those 52 patients had extraocular muscle involvement with diffuse ophthalmoplegia as the most common presentation, followed by 3rd cranial nerve palsy, involvement of both 3rd and 6th cranial nerve in 7 patients, and involvement of only the 6th cranial nerve in 3 patients, and none had isolated 4th cranial nerve involvement. So at presentation, 29 out of those 52 patients had best corrected visual acuity of less than 20 by 200, and 23 patients had best corrected visual acuity of more than 20 by 200 at presentation. And out of the 20 patients with follow-up visit at 3 months, 13 patients had best corrected visual acuity of less than 20 by 200. And the optic disc morphology ranged from a normal fundus, which was seen in 30 patients, and diffuse disc edema in 3 patients, and optic atrophy in 17 patients. The mean deviation on Humphrey visual fields, which was possible for 21 patients, was minus 11.18 decibels in the affected eye. And out of those who had a follow-up, the mean deviation improved to minus 4.4 decibel at last follow-up. And they underwent the investigations as I mentioned before, and majority of the patients had an abnormal MAN2 test, which was recorded as abnormal in 9.6% patients, and an abnormal endoscopy in 9.6% patients respectively. Then the MRI findings in patients more than 40 years of age was, the leading cause was a non-specific inflammation, which was followed by fungal etiology. And in less than 40 years of age, the leading cause was again non-specific inflammation followed by granulomatous etiology. These are some of the representative lesions on MRI which we found in our patients. And 33% of the patients received oral steroids, and 25% patients received IVMP, and others received antibiotics or antifungals according to the etiology. So there was a predominance of orbital apex syndrome among females, and the presenting complaints were diminution of vision in 76.9% patients, and followed by diplopia, periocular pain, ptosis, and proptosis, and majority of the patients presented with extraocular muscle restriction. And diffuse ophthalmoplegia was the commonest form of motility restriction. And visual acuity was worse in 2200 in 55.76% patients. And MRI findings revealed non-specific inflammation and fungal etiology as the leading causes of orbital apex syndrome in patients aged 40 years and above, and granulomatous etiology and non-specific inflammation in patients less than 40 years. Thank you.
So in post-COVID, we had more of fungal problems. Were those cases also included in this case series?
Yes, because it was done from 2018 to 2022, so we did include COVID, like the patients presenting during COVID.
We did attempt to see whether the COVID is influencing increased risk of mucormycosis and causing orbital apex syndrome versus the patients otherwise, and that's why we also tried to do a subgroup analysis that whether patients who are less than 40 and more than 40 are likely to have difference in the etiology. So we did find that patients with COVID, the orbital apex syndrome was more likely due to mucormycosis.
Definitely fungal etiology is definitely not that easy to get a good result. Other than that, in your series, what is the commonest cause that has affected the orbital apex syndrome, and what was the visual outcome? What was the cause which is given you the best visual outcome? What was the cause which is given the worst, other than the mucormycosis?
The ones which were diagnosed as Tolosa-Hunt syndrome, they received IVMP and oral steroids. They had better visual prognosis compared to the fungal etiology or IgG4 disease.
Fungal etiology, leave it. That itself is a problem. Other than that, what are the observation? Because that gives you a sort of an idea to the student that this is the problem which we have to treat to get the good results.
Chronic granulomatous inflammation, either proven due to, either presumed due to tuberculosis, or those with Tolosa-Hunt syndrome had a best outcome.
You mentioned ENT procedures. What are the commonest ENT procedures you faced with this orbital apex syndrome?
Actually, during COVID time, some of the patients, they underwent diagnostic nasal endoscopy and biopsy. Thank you.
Thank you. Thank you.
So next we have Dr.
nerve fiber layer myelination and visual loss. Strathma syndrome is a rare disease entity characterized by the triad of unilateral myelinated retinal nerve fiber, axial myopia, and amblyopia. Variations of the triad include a reverse Strathma syndrome, in which patients exhibit hyperopia instead of myopia. Traditionally, it has been considered a uniocular disorder, but cases of bilateral Strathma and bilateral reverse Strathma have also been reported in literature. So the case is a 29-year-old male presented with painless progressive diminution of vision in both eyes since 2 years. There is no association, aggravating and relieving factors, no diurnal variation. There is no history of any systemic illness, no relevant family and personal history, and general and systemic examination were within normal limits. The anterior segment examination was within normal limit, with the uncorrected visual acuity in right eye 3/60 and in left eye 6/18 partial, and improving with pinhole to 4/16 in right eye and 6/12 partial in left eye. So this is the cycloplegic AR findings, which in which there is a spherical power of plus 11.5 diopters in right eye and plus 5.75 diopters in left eye. So on dilated fundus examination, we see bilateral type 1 retinal nerve fiber layer myelination. OCT macula is within normal limits, and OCT optic nerve head shows retinal nerve fiber layer thickening. Systemic evaluation was within normal limit. Treatment, full refractive correction with plus 6 diopter spherical in right eye, which improved the vision to 5/60 and N36. And in left eye, it is plus 3.75 diopter spherical, which improved the vision to 6/6 N6. Coming to discussion, in 1856, Rudolf Virchow first described myelinated nerve fiber as thick, opaque, chalky white spots which spread around the disc in a shape of star. Rare lesions that were observed in only 0.98% of individuals and 0.0554% of eyes in large study of 3,968 autopsies conducted by Stratzma. It is generally isolated findings but can be associated with various ocular and systemic abnormalities. They are commonly asymptomatic, and their effect on visual function is highly variable depending on the location of the lesion and the extent of the lesion. According to the location, myelinated nerve fiber can be classified into type 1, type 2 and type 3. Type 2 is was usually associated with worse prognosis. Bradley Stratzma et al. First described Stratzma syndrome in 1979 as unilateral myelinated nerve fiber in association with myopia, amblyopia and strabismus. Accompanying strabismus has been reported, but there was no strabismus in our case. Myelinated nerve fibers are more common in myopia than in hypermetropic eyes. In patients with bilateral hypermetropia, myelinated nerve fiber occur in the eye with lower refractive error, which is consistent with our case. The most critical and challenging part is the associated amblyopia and its treatment. An important prognostic factor, according to major series in the literature, seems to be the degree of anisometropia. Because of poor visual acuity outcomes, despite aggressive therapy, Ellis et al. Postulated that an organic etiology may also be present. In a recent series of 3 patients with Stratzma syndrome, poor visual acuity was associated with loss of disturbance of the ellipsoid zone, and was postulated that organic pathology is present with poor prognosis, which might be related to that. However, in our case, the ellipsoid zone was intact. Reverse Strassmann syndrome seems to be generally associated with poor visual outcomes, especially in treatment with in patients with post-treatment visual acuity predictors such as deep anisometropia, strabismus, type 2 myelination, extensive myelination, and macular involvement. However, there are several reports of unexpectedly good response in the literature, even in patients with these predictive factors. All patients should be approached optimistically and provided aggressive amblyopia treatment with appropriate refractive correction. Thank you.
Well documented.
Thank you, sir.
What is the educational status of the patient?
Sir, he was not educated, sir. We had to use it with
That answers
C-chart,
everything. He has come to the hospital in 29th year saying that he has some problem.
Yes, sir.
Though one eye is absolutely a very high power, plus 11,
Yes,
other eye is also having an error. And most probably that explains everything, because he is not bothered about the vision, whatever it is. He accepted whatever vision is having.
Yes,
Thank
sir.
you.
Thank you, sir.
Again, congratulations, well documented case.
Thank you,
These
sir.
are rare cases.
Yes, sir.
So, what according to you is the difference between the Strassma and reverse Strassma syndrome?
Sir, it is, sir, in Strassma, sir, there is myopia, but in reverse Strassma, there is hypermetropia, sir.
Very good. So, and what is the cause of poor vision usually? Is it related to myelination or is it related to amblyopia?
Sir, it is because there is more degree of anisometropia which leads to amblyopia, sir.
So that is a very important message everybody should carry that at least part of the vision can be recovered in majority of these patients because the amblyopia is due to anisometropia. Thank you.
Thank you very much.
Next we invite Dr. Shruti to present on the clinical study of role of OCT in Parkinson's disease.
Good morning, everyone. I'm K. Shruti, second year postgraduate from Andhra Medical College, Visakhapatnam. I'm here to present a paper on a clinical study on the role of OCT in Parkinson's disease. Financial disclosure, no conflict of interest. Coming to introduction, idiopathic Parkinson's disease is a common neurological disease characterized by selective loss of dopaminergic neurons in the nigrostriatal pathway, resulting in progressive motor and non-motor symptoms. Here, visual dysfunction is presented as decreased visual acuity, decreased color vision, contrast sensitivity, and motor perception. These visual defects may be due to loss of dopaminergic denervations of amacrine retinal cells, which is essential for light adaptation. Recently, there is a reduction in retinal nerve fiber layer thickness has been found in neurological diseases, which is normal of 101 plus or minus 10.13 microns. aim of my study is to evaluate retinal structural changes in Parkinson's disease and to establish the role of OCT in Parkinson's disease. This is a prospective study conducted in Government Regional Eye Hospital. The sample is from Department of Neurology, Andhra Medical College, Visakhapatnam, from January 2023 to May 2023. Primary Parkinson's disease in the age more than 40 years of both sexes were included. Patients having prior history of optic neuropathy, maculopathy, glaucoma, high myopia, dense media opacities, age-related macular degeneration, peripheral vasospasm, sleep-related breathing disorders, ocular trauma, and ocular surgery were excluded. Detailed histories were taken and all the patients underwent ophthalmological testing, including visual acuity, color vision, slit lamp examination, intraocular pressure measurement, visual fields with automated perimetry, fundoscopy, and OCT. OCT was performed with Cirrus SD-OCT. The OCT imaging was performed with the patient's pupils dilated to obtain higher signal quality and discarded if signal strength was less than 8. Average temporal, nasal, inferior, superior quadrant, peripapillary, RNFL thickness were obtained from the OCT. Coming to results, most of the Parkinson patients are male, almost 72%. Age distribution, most of them come under 51 to 60 years, that is 39.3%, followed by 41 to 50 and 61 to 70 and 71 to 80. Coming to visual acuity, all are between 6.6 to 6.36, most of them in between 6.18 to 6.24. Color vision is abnormal in almost 25% of them. Coming to visual fields, most of them are unreliable, and in compared reliable, 30% are having arcuate scotomas and 30% are having decreased superior field sensitivity. Coming to RNFL thickness, average RNFL thickness in Parkinson is 89.91 plus or minus 8.2 microns, significantly thin compared to normal. Compared RNFL thickness in normal versus Parkinson. IOP and slit lamp examination is within normal range. Color vision is abnormal in almost 25% and are inconsistent with RNFL thickness. OCT reveal reduced RNFL thickness in temporal quadrant of Parkinson's followed by superior and inferior quadrants. Almost all the patients in our study are having normal mini-mental state examination, so there is no cognitive decline. A study by Inselberg et al. And Mostius et al. Also found selective thinning of RNFL in the temporal quadrant, similar to our study. And these are other studies similar to my study. Conclusion, this study shows a significant decrease in RNFL thickness in temporal quadrant followed by superior quadrant in Parkinson's disease. Further studies should be conducted with prospective long-term follow-up and investigations to elucidate data from a larger sample about retinal structural and functional changes in the course of disease. This helps us to know whether OCT can be used as prognostic marker for Parkinson's disease in future. These are my references. Thank you.
How did you choose the controls for measuring the RNFL thickness?
Normal RNFL according to journals, I didn't take controls.
You didn't have other subjects,
no,
you just took it from literature.
Yes.
Okay.
You were comparing with the normative database.
Yes.
But all degenerative diseases going to give you a nerve fiber layer reduction.
Yes.
So it is not a diagnostic value, even if it is
prognostic.
Yeah, even prognostics wise, you can't say just because it has come down to the 10%, you can't say your prognosis is bad. So we can't say like that. It's only an indicator that what is the activity is going on, how much is the degeneration going on, we can say is going or not. That's the only thing we can say. We cannot say the complete prognosis or the visual prognosis as such.
Okay.
So it's a degenerative disease, but affects mainly the afferent system or efferent system?
Efferent system.
So it's affecting the efferent system. Okay. So why the RNFL change is expected in this disease is first question that you should think. And if it is there, how is it useful? As sir was saying, it is primarily for the prognosis. So is it there is enough literature that tells that it can serve as a biomarker of the progression. So the study should be done for a longitudinal follow-up of these patients. A cross-sectional study without any controls may not carry much added knowledge to the existing literature.
Thanks.
Next, I invite Dr. A. Anjani to present on a clinical clinical study of role of VEP in optic neuritis patients.
Good morning, everyone. I am Dr. Anjani, second year postgraduate from AMC Visakhapatnam. Today I am going to present a clinical study on the role of visual evoked potential in the optic neuritis patients. Financial disclosure, no conflict of interest. Introduction: optic neuritis is an inflammation of optic nerve due to primary demyelinating process, mainly multiple sclerosis, and it is secondary to other causes like autoimmune infections or idiopathic. And this inflammatory process mainly causes the degradation of myelin and destruction, leading to poor conduction of impulses by the axons, and most commonly seen in around young females around 18 to 42 years, and mainly characterized by sudden loss of vision, field defects, relative afferent pupillary defect, and decreased color vision. And visual evoked potential, it measures the electric signals produced in the brain in response to stimulation of retina. It depends upon integrity of visual pathway. Here the pattern reversal is recommended because in addition to inter and intra-individual, variability is minimal compared to no pattern stimulus and detects the minor visual pathway abnormalities with a better accuracy. It is recorded using 3 electrodes placed in occipital region with a mid-frontal reference electrodes. And signal on mid-occipital electrode has a prominent positive component called P100, which is preceded by N75 negative wave. An elongation of P100 wave latency reveals the number of demyelination and amplitude related to axonal degradation. These are some of the patients with optic neuritis fundus pictures. And aims and objectives: to study the role of VEP in optic neuritis patient and determine the characteristics of VEP in them. Materials and method: this is a descriptive cross-sectional study done in optic neuritis patient in Department of Ophthalmology, Tertiary Eye Care Hospital from Jan 2023 to June 2023. And inclusion: 50 optic neuritis patient attending the ophthalmology OPD and neurology OPD clinically diagnosed as optic neuritis included in the study. And exclusion: patient with other known history of glaucomatous optic neuropathy and other optic nerve and retinal disorders are excluded. Patients aged from 15 to 79 years, both sexes were considered and subjected to detailed history. Visual acuity is measured, RAPD examination done by swinging flashlight test, and color vision tested by isochromatic Ishihara chart, fundoscopy done using direct indirect ophthalmoscopy, and VEP done using pattern reversal technique, and the readings are noted. Results: out of 50 patients, we found that 58% are found to be females and 42% are males. And age-wise distribution: population divided into 6 groups, and majority lies in between 36 to 50 years, that is 46%, followed by 51 to 65 years, that is 24.6%. The same depicted in the graph. And in VEP recordings, the mean latency waves, that is N75, positive P100 wave and negative 145 and amplitude were considered, and following results were obtained. In increased P100 latency and reduced amplitudes were found in majority of the cases, that is around 62%, and normal latency and reduced amplitude around 22%, and both the amplitude and latency are found to be normal in around 16% individuals. These are some of the recordings. Based on the recordings of the VEP findings, that is majority of patients have both optic nerve lesion, that is 45.20%, and followed by the left eye lesion, that is 24.80, and 13.10 is right eye, and normal is found in around 16.70%. Based on above results, most of subjects are young adults, typically ranging between 36 to 50 years, and the mean age is around 38.4 years. According to results, majority have a prolonged latency and reduced amplitude, that is around 62%, and 16% individuals having normal VEP values. In this study, it is also concluded that dominant VEP of optic nerve lesions were both right and left, that is around 45.2%, and in acute and the acute optic neuritis patients with the normal VEP findings are around 16.7%. These are some of the studies that are correlated with my study. Conclusion: based on our study, we noted that majority were young adults and there is female preponderance, and characteristics were prolonged P100 latency with a low amplitudes and showed predominantly both the left and right optic nerve lesions. In optic neuritis, the P100 waveform is found to be the most informative index, where VEP plays a key diagnostic role, but along with the other optic nerve function tests in detection of optic neuritis, it is a sensitive diagnostic tool, but it is not specific. These are my references. Thank you.
VEP is not a diagnostic tool for the optic neuritis because it has no localizing value. And second thing is, you have not mentioned about the refractive status of all these patients. And what was the refractive status of the patients and what were the corrections were given, and those things you have to mention about it. Otherwise, there is no point in saying that VEP is correct or not. If I don't see properly the checkerboard, I get a low value. And if I see checkerboard correctly, I may get a better value. So you have to mention about that. That you have not at all even suggested in there. So that requires some correction.
Yeah, that's important. We have to provide the reflective correction and mention about it. Did you also also find a difference in the latency between two eyes in any patients where it was unilateral disease, like right eye was affected versus left eye was normal? Was there a difference in the latency of
Yes,
these
sir.
patients?
Interocular latency differences.
Did you can also add that also to the, this is well known, what you have presented is very well known in the literature. Majority of the patients have these findings, but as sir said, it is not the only diagnostic tool. We can use it as supportive evidence. Thank you.
So any correlation with the RAPD? You say 16% have normal VEP.
No,
So how
sir.
do you really diagnose as a confirmatory thing for patients with
Actually,
if the
they
optic
were
nerve is looking fine, how do you really make a diagnosis?
means I didn't compare with RAPD, sir. Generally, I have mentioned only VEP normal patients. Means some of them is also having normal because they have already received treatment in of the neurology department, sir. So they may have normal VEP values, sir. So they are referred from there. So I got the normal.
They may not have a normal VEP because VEP almost
for
never
some
normalizes classically in a patient with optic neuritis. Up to 80% of patients will have persistent change lifelong.
Yes.
So it should not normalize in a very short span of time, even the amplitude should not recover. But sir's question is how you diagnose these patients as optic neuritis. So they were diagnosed based on clinical and radiological findings, I believe.
Yes.
VEP has a very good tool to evaluate the recurrent optic neuritis patient. Suppose you have already documented several times, they have recorded well about the previous status of the VEP, you know, and if you carefully follow them, anything minor changes, you can easily identify them when the other causes are not there. In the sense there are no other media problem, no other thing. Definitely you can say a recurrent attacks of that. It is going to be a useful tool to diagnose, or at least know how much is the problem, how much we are recovering. These things we can identify by that. Otherwise, as such per se, it is not a diagnostic, but it is only to identify you certain features. That's all.
Okay.
So next we have Dr. Bhavani Pasupula, a study of clinical profile of optic disc edema in patients above 18 years at tertiary care center.
Very good afternoon to one and all present here. I am Dr. Bhavani from Sarojini Devi Eye Hospital, second year junior resident, here to present on a study of clinical profile of optic disc edema in patients above 18 years. Author being myself and co-author being Dr. Adal Gupta sir. I have no financial interest. Optic disc edema, it is defined as an axonal distension and elevation of the optic disc, whereas papillary edema is a term which is exclusively used for the bilateral optic disc edema, which is secondary to the intracranial increased intracranial pressures. Swollen optic disc edema, choked disc, or elevated optic disc are the terms which are frequently used to describe the swelling of the optic nerve. The clinical causes for unilateral are most commonly the optic neuritis, the non-arthritic anterior ischemic optic neuropathy, compressive optic neuropathy, etc. Whereas bilateral, there are papillary edema, there is intracranial space occupying lesions, idiopathic intracranial hypertension, and malignant hypertension. The aims and objectives of my study are to determine the clinical manifestations and etiology of the optic disc edema, and my study is an attempt to prioritize the diagnosis. It includes both unilateral and bilateral optic disc edema. Materials and methods, it is a non-randomized prospective case study in the patients presenting with optic disc edema with unilateral and bilateral presenting to the ophthalmology OPD. All patients, we underwent a complete medical examination including blood count, blood sugars. Wherever necessary, we have advised for a CT-MRI scan also. A complete thorough ophthalmic examination including anterior segment, pupil examination, slit lamp examination, and optic disc evaluation was done to these patients. Inclusion criteria for my patients were the proven case of optic disc edema and the proven case of papillary edema, whereas exclusion criteria are the cases of pseudopapillary edema. Coming to the analysis, in my study, the female preponderance is major. They are up to 64% of my patients are female, and 34% of them are male. Distribution of patient in relation to laterality, 29 patients of them have unilateral disc edema, whereas bilateral, 21 patients show bilateral disc edema. Distribution majority of them fall under the age category of 31 to 40 years, followed by greater than 50 years. Coming to various etiology, in my study, the majority of them have optic neuritis, like 18 patients have optic neuritis, followed by retinal vein occlusions, and some of them have intracranial space occupying lesions, idiopathic intracranial hypertension, IIH. The major symptoms are the diminution of vision associated with the headache in intracranial space occupying lesions. Coming to the best character visual acuity, most of my patients fall under the BCV of 6/6 to 6/18, and followed by 3 CF 3 meters to PL positive. Associated systemic conditions, 44% of them have diabetic mellitus, 40% of hypertension, 2% of them have HIV and epilepsy, 4% have CAD, and 24% of them have no clinical comorbidities. Coming to the case presentation, this is regarding a 21-year-old female presented with chief complaint of right eye diminution of vision since 5 days. Anti-segment evaluation showed grade 2 RAPD. We have subjected her on to dilated fundus examination. There were significant disc edema in the right eye with the distribution of the multiple hemorrhages along the superior temporal vein. FFA was advised for this patient, which shows blocked hyperfluorescence and disc ischemia. So after thorough evaluation, we diagnosed this patient as optic neuritis and started her with a standard therapy of intravenous methylprednisolone. This was after 1 week after the treatment. There was significant improvement of the visual acuity and also diminution of the hemorrhages, as you can see. The case 2 is of a 36-year-old female which was referred to the ophthalmology OPT because of the holochronal headache. There were no systemic comorbidities. BCVA in both the eyes was 6/9. Anti-segment evaluation was normal. The patient has grade 4 papilledema in both the eyes. She was then subjected to MRI scan and CSF analysis. MRI was normal, whereas CSF analysis, which all the parameters were normal except the opening pressure, which was of 280 mm. We then diagnosed this patient for intraocular and idiopathic hypertension and started with the acetazolamide standard therapy, 250 mg QID. Coming to the third case, a 65-year-old patient presented with chief complaints of DOB in right eye since 6 months. Known hypertensive, he has altered lipid profile with deranged cholesterol and triglycerides. On anti-segment evaluation, there was a grade 2 RAPD, with the rest of the evaluation being normal. On dilated fundus examination, there was significant disc edema with multiple hemorrhages. He was diagnosed with right eye central retinal vein occlusion and started with intravitreal Avastin therapy. Conclusion, we found that the common etiologies of optic disc edema were optic neuritis, idiopathic intracranial hypertension, retinal vein occlusions. Majority of patients were female with united presentation. The common complaints were decrease of vision and headache. With causing ranging from the infectious to vascular to the malignant, the swollen optic disc is a crucial, often mystifying sign. Patient vision or life may depend on the timely diagnosis, hence early detection and management are essential to prevent the progression of disease and loss of vision. These are my references. Thank you.
Thank you, Dr. Bhavani. I think that's important for us to know about what is the clinical profile and final diagnosis in these patients. But it's a big mixture of things. Yes. When you say optic disc edema, unilateral, bilateral, with vision loss and without vision loss, it is going to be a mixture of things. So you can subclassify your results later on as patients with papilledema versus optic disc edema. That will segregate the disease being in the brain versus in the eye. And then in that you can represent the results with vision loss and without vision loss. That might give you more meaningful information. Thank you.
What was the commonest cause you have found amongst the youngsters?
It is optic neuritis, sir. Majority of them from 21 to 30 years have presented with optic neuritis only.
Yeah. Older generation?
Older generation retinal vein occlusions are more common in hospital settings, sir. Like central retinal vein occlusions are more common. Some of them have IIH, idiopathic intracranial hypertension.
Okay, thank you.
Thank you, sir.
Use the mic.
Non-arthritic, yes, ma'am. No, ma'am. No, ma'am. Non-arthritic only.
Yeah, the visual acuity, I think she summed up,
Yes.
as Sir said, it was of all the cases, we really don't know which diagnosis had what kind of a visual acuity. As I said, it's better you concentrate one diagnosis and then explain it much. Thank you.
Thank you. Next, we invite Dr. Harika Premavada to present on factors predictive of recurrence in emerging positive optic neuritis.
Good afternoon, respected judges and one and all. I'm Dr. Priyamvada, here to present my paper on factors predictive of recurrence in myelin oligodendrocyte glycoprotein MOG positive optic neuritis. We have no financial disclosures. MOG is a IgG1 antibody-mediated autoimmune demyelinating disease with the spectrum of optic neuritis, encephalitis, and myelitis, where optic neuritis is the most common presentation. It is a distinct entity from multiple sclerosis optic neuritis and NMO optic neuritis, and the incidence of MOG optic neuritis is more than multiple sclerosis optic neuritis in Asian countries, especially India. Acute unilateral or bilateral optic neuritis with papillitis, long segment involvement of optic nerve, being steroid responsive, having recurrent episodes are the hallmark findings of MOG optic neuritis. Recurrences may occur in about 1/3 of cases. However, there is limited prior literature on these aspects. Hence, we aimed at identifying the factors predictive of recurrences in MOG patients. Ours is a retrospective observational study comparing the recurrent and non-recurrent cases done at a tertiary eye care center, LVPI, in India between 2019 and 2023. Though some of our patients have clinically MOG positive, but we only included those who are serologically positive for MOG antibody and negative for NMO, and we preferred cell-based assay because it is gold standard. We included patients of all age groups with a minimum follow-up of 3 months, considering 3 months is required to document a recurrence. Electronic medical records of 72 patients were reviewed, and the data was collected for age, gender, clinical features, best corrected visual acuity, optic disc findings, constitutional symptoms like pain, fever, and neurological symptoms like ataxia, headache, seizures, and limb weakness. MRI or brain and orbits were studied for the involvement of the segment of optic nerve. HVF mean deviation and pattern, OCT, RNFL thickness, and MGCL thickness were compared. Treatment is given with IV methylprednisolone, and the days of treatment is compared. Immunosuppression is with azathioprine, rituximab, and MMF is given, and those data are compared. Visual outcomes and number of recurrences were also documented. A total of 48 patients met the study criteria and were divided into 2 groups, recurrent and non-recurrent. We did a statistical analysis using Stata software, and p-values less than 0.05 were considered significant. These are our results. 27 and 21 patients respectively were included in the recurrent and non-recurrent groups. Though our patients' age range from 1.5 years to 61 years, the median age in the recurrent group is 37 years and 23 in the non-recurrent group. Yes, our patients are slightly older in the recurrent group, but there was no statistical significant difference between the groups. There was no gender predilection. Constitutional symptoms, neurological symptoms, papillitis, long segment involvement, posterior optic nerve involvement are all respecting the previous data, but there was no statistical difference between the groups. The statistically significant differences we found are unilateral presentation is more in recurrent group, pain on eye movements was more in recurrent group, and immunosuppression when not started had more number of recurrent cases. So these are the depiction. 59.3% patients had pain in the recurrence group, whereas only 33% patients had pain in the non-recurrence group. So the proportion of pain was statistically significant higher in the recurrence group as compared to the non-recurrent group. Similarly, the laterality, there was statistically significant difference in the laterality since the majority in the recurrence group had OS as a presenting eye, that means the unilateral presentation, whereas majority in the non-recurrence group are bilateral presentations. We also found that immunosuppression at first visit when started showed less number of recurrent cases, and these were the data depicted in the table and pie charts. Most of our patients had long segment optic nerve involvement, and the following charts depict the distribution of the data. Best corrected visual acuity at the present and the final follow-up acuity are not didn't show any significant difference in the groups, but the p-value within the groups, that means the logmar value of 2 has improved to 0. That means they are improved very well with the treatment IV methylprednisolone and the immunosuppression, and the prognosis is good in both the groups, and it is very much statistically significant. Similar findings were seen with the mean deviation on HVF, so that also indicates that there is a good prognosis and which is statistically significant within the groups. The distribution of other data are depicted in the following slides. More patients had papillitis presentation, long segment involvement. Similar studies studies similar to our data showed young adults and standard first-line immunosuppression or prednisolone were associated with decrease in risk of relapse, which is similar to our results. The major strength of study is that it is one of the largest studies of MOG antibody disease and one of the first studies comparing the recurrent and non-recurrent cases. Limitations being its small sample size, especially in respect to the statistical analysis. So we conclude that pain on eye movements and unilateral involvement were the factors associated with increased risk of recurrence in MOG optic neuritis. Treatment with immunosuppressive agents at first episode of optic neuritis have shown less rates of recurrence. Understanding the long-term relapse risk may help clinicians to decide on when to start the immunosuppression treatment. However, larger further prospective randomized control trials are needed to validate these observations. These are my references. Thank you.
Well done study. What is the most important predictive factor you have found? Pain is the only one?
So depending on the statistical analysis, unilateral presentation was more significant, sir. And we also found that having presence of pain on eye movements while presentation is also statistically significant. And also starting immunosuppression at the first episode was also statistically significant, sir.
So those associations are by univariate analysis. Did you do a multivariate analysis? Because there may be many other factors, because you have chosen as MOG plus or minus.
Yes, sir.
So how many cases did you exclude from the sample size? Because you have a small sample.
So we actually almost screened 700 plus patients, and those who are MOG positive are 72. But we took at least 3 months follow-up is needed. That's why we had a small sample size. Multivariate analysis we can do, sir, but univariate analysis is better because the sample size should be at least 30 in both the groups to compare with the multivariate analysis. But the univariate analysis, it definitely proven all these statistically significant values, sir.
Okay. That's why multivariate was, the results were calculated, but we did not present because the sample size is not 30 at least in each.
Okay. Yes, sir.
Good. Thank you.
Thank you, sir.
So next we have Dr. Virendra sir presenting on clinical profile and predisposing factors for recurrent idiopathic intracranial hypertension.
Yeah. Thank you everyone, and thank you AIOS for giving me the opportunity to present this work titled Clinical Profile, Outcome and Risk Factors in Recurrent IIH. So, yeah. So while we all know that idiopathic intracranial hypertension commonly presents with blurred vision, headache, and at times with diplopia, and is commonly affects young to middle-aged women more commonly than men, and majority of patients are obese. What is also known is that majority of patients tend to have good resolution with compliant therapy in majority of cases, but there is a very limited data regarding the recurrence in IIH. So according to a prior study, Rowe et al. Studied patients over a period of 6.2 years, and they found that about 38% of them did develop a recurrence. So with this intention to look at a cohort of patients from our own settings, we tried to identify patients who had a recurrent IIH. We wanted to find out in how many cases it recurs. We studied the demography and clinical profile, visual outcomes, and any predisposing risk factors for the recurrence. So it was a retrospective study including patients from January 1, 2016 to March 30th, 2021. We took prior approval from ethics committee and followed the ethical guidelines. Data was collected regarding the patient clinical profile, demographics, laterality, visual function,
radiological changes of IIH, number of recurrences, optic disc morphology, and what type of medical treatment had been given. Appropriate statistical analysis was attempted using Stata software. So coming to the results in brief, we found a recurrence developing in 41 out of the 449 patients that we identified during this period. That means 9% or 1 out of 11 patients with IH can go on to develop a recurrence, which means that it is not very uncommon. As regards the demographics, the patients were 87% of them were women, and median age was around 35 years. So coming to the presenting complaints of these patients, about 50% of patients had headache as a presenting complaint, and about 45% of them had blurring of vision as the main complaint. Vomiting and diplopia was seen in a minority of patients. If we look at the optic disc findings, majority of them, over 75%, had grade 2 or 3 disc edema. So that means it is not difficult to pick up the recurrence occurring, because majority of them have well established papilledema at presentation. If we look at the visual function of these patients, despite having significant disc edema, majority of them had a best-corrected visual acuity of 20/25 or better in majority of cases. And if we look at the visual fields, majority of them had a mild to moderate visual field loss with mean deviation of about 6.3 decibels. Majority of the patients again had enlargement of blind spot, which is the classical field effect that we see in established papilledema at presentation. Importantly, we try to look at the systemic comorbidities and BMI of patients. We found that anemia was noted in about 30% of patients with recurrent IIH, followed by hypothyroidism. Rest all, such as PSCOD, systemic hypertension, diabetes, were seen in isolated cases. If you look at the data about the weight at the presentation of recurrence, the data was available from about 19 patients, and majority of the patients did have overweight or a obese category. The median CSF opening pressure was 35, which means it is pretty elevated. We also looked at the radiological findings, and we found that sinus hypoplasia was noted in 10 out of 41 patients. That means 1 out of 4 tend to have a sinus hypoplasia, and in majority of cases it was transverse sinus hypoplasia. Majority of patients had only one episode of recurrence. As regards the treatment, the patients in the first episode had been treated with medical management in majority. Only 3 had undergone a shunt surgery. And none of the patients who underwent shunt surgery went on to have a recurrence in this setting. So majority of the patients were managed by medical therapy. If we look at the final visual outcome of these patients, they tended to have a very good visual outcome in majority, with significant improvement in visual acuity and visual fields. We try to compare these patients as compared to the IH representative group who had first episode, and we found that there was no significant difference in terms of age, gender, and BMI. We also try to look at the systemic risk factors. As I said before, anemia was noted to be a very significant risk factor in patients who had recurrent IIH, and the visual field differences was noted in the terms that none of the patients with recurrent IIH presented with an advanced field defect, whereas there were few eyes who had advanced field defect at primary presentation. The clinical characteristics were not different. The logistic regression analysis showed increased risk of recurrence with sinus hypoplasia and anemia. So coming to the strengths and limitations, it's a fairly large series of patients with recurrent IIH, given it occurs in only about 9% of patients. However, we had lack of uniform data about weight, anemia, and risk factor at each follow-up. Though now we do prospectively for all patients, it was not there previously. Many patients did have short follow-up, and longitudinal outcomes could not be assessed. So in conclusion, recurrence might occur in patients who are women. The majority of patients do tend to have good visual outcome with timely treatment. Transverse hypoplasia and anemia could be associated with increased risk of recurrence. However, more studies are needed to confirm this. Thank you. These are my references.
Well documented, sir. Only thing is, exceeded your time.
Yes.
Here I would like to have some clarification. Which sinus is hypoplasia, and on that, you give any idea about the speaker?
Yes. So transverse sinus was hypoplastic in 9 out of the 10 patients, and it can be seen in otherwise in commonly also, like about 25% of the patients tend to have one side as dominant. So that's why it is difficult to prove without having a bigger study whether this is really contributory or not. At this point of time, this is an association we have found, and we would like to test it with larger multicentric studies.
Can you say one word to the youngsters that whenever you see
IOCs.
MR angio, try to see the transverse sinus hypoplasia and try to have a cautious about it. Is it going to help them?
Yes, sir. MR venogram, look carefully for the signs of hypoplasia.
So signs of hypoplasia on a transverse sinus is going to help you and giving you some sort of insight to identify these patients developing this problem. So you try to be very careful about and identify that whenever you see a MR angio.
Yes, and also like correct anemia and prevent recurrence of weight gain. Thank you. So data was there. We did saw in about 20% of patients they might have coexisting abnormality. However, as per prior literature, there is no correlation.
Use the phone. You may use the microphone.
Yeah, they were our own. No, the first episode was treated by us. I think about 90% of them have been treated by us previously. However, there are about 10% of patients who have been treated elsewhere also, and they have come to us. We had records. All the patients are like those who have been treated. Disc edema has been documented to be resolved, and then they have come back with a problem.
Thank you, sir. We're going on to the next one. Ravi Naini, case on a papilledema in a young unveiling COVID-19 connections.
Good afternoon, everyone. I am Dr. Naini. Good morning, everyone. I am Dr. Naini here going to present about the papilledema in an unveiling COVID-19 connections. So there are no financial conceit and interest. So coming to the background, as we all know that IIH is a rare disorder characterized by increased intracranial pressure of unknown cause, but it is associated with SARS-CoV infection, which is described since the beginning of the pandemic. So in the cohort study of hospitalized severe COVID-19 patients, there are almost 45.5% of neurological complaints. So however, there is a still controversy surrounding the diagnostic criteria of IIH. So the main aim of our study is to evaluate the causes of papilledema in the young age group following COVID-19 infection or COVID-19 vaccination at Jimsar Teaching Hospital, Visakhapatnam. It is a cross-sectional case series. We have taken 84 young patients were screened in Ophthalmology Department, Jimsar, Visakhapatnam from the period of 2022 to May 2023, and patients were evaluated under the modified DANCE criteria. So here we have done the comprehensive assessments including ocular examination, visual field testing, and the brain imaging were done mainly in the diagnosis of the cause of the papilledema. So here the patients were treated symptomatic by the neurologist like isdazolamide and IV mannitol and anticoagulants, etc. So the inclusion criteria are patients who are above 15 years, and the patients had the previous history of COVID, post-COVID and post-COVID immunization within 6 months of period, and the patients who are used steroids during the COVID effect. So in our exclusion, we have excluded 15 years below 15 years patients, and patients already who had the previous history of coagulopathies, abnormal prothrombin factors, neurological diseases, and patients who are recovered from COVID-19 6 months beyond and post-COVID immunization beyond 6 months. So in our results, out of 84 patients, 18 patients are diagnosed as papilledema. Out of that, 12 are female and 6 were male. So in that, mainly 3 are obese, who are mostly of a female, and the mean age is 22.5 years, and 5 patients have the use of history of oral contraceptive use, and there is no history of steroid intake. So this is one of the patient's picture which is showing the bilateral papilledema of elevated disc bilaterally, and which shows in the left side shows the hemorrhage. So here the another picture of the following patient which has the symptomatic relief of and regression of papilledema within 4 to 6 weeks. So coming to our distribution of papilledema, out of 18 patients, IAH is seen in 11 patients, and cerebral venous sinus thrombosis in 4 patients, and meningitis in 3 patients. So this is the MRI scan which shows the subarachnoid space in the optic nerve sheet. And in our discussion, mainly in our study, IAH is seen in 11 patients, as I have told. The main hypothesis, it may be due to increased intracranial venous pressure and venous outflow abnormalities, and there may be any intracranial vascular clotting. So cerebral venous sinus thrombosis is seen in 4 patients in our study, maybe due to it associated with coagulation dysfunction. And the main pathognomic mechanism can be increased levels of von Willebrand factor and systemic inflammation pro-coagulative state. So CSVT generally prevalence is higher in patients with COVID-19, reaching 0.02% to 1%, mainly in hospitalized COVID-19 patients. So in my conclusion and take-home message, the upsurge of IAH may suggest a potential association between the IAH and the related pandemic, and the further studies etiopathogenesis in this age group are to be considered. And here therefore it is advisable to consult the latest medical literature and studies for the most up-to-date information on the connection between the IAH and the COVID-19. These are my references. Thank you.
Yeah. Well documented and well presented. What is the type of COVID vaccine they have taken it? You have any idea about that? You noted down?
Yes, sir. I have taken. Most of them have taken the shield, sir. COVID shield.
COVID shield. Okay, so there is another factor which is also questioned several times. I do not know the validity of it finally.
So, you want to ask which vaccine kind of thing? Yeah. So, Covishield and AstraZeneca vaccines have reported to have more complications as per the report. The neurological complications are more commonly reported with them. How did you define the temporal association? Within what time of the COVID infection or COVID vaccination the patient should have developed?
In general, we have taken within 6 months period.
6 months is, don't you think it's a too big a period to cause? So during that time a person can have recovered and could have gone to develop.
Yes,
also you noted 3 patients had meningitis. How was the presentation different in them?
Generally the correlation of idiopathogenesis is not known till now. The connections.
There is a proposed mechanism that either hyperfiltration
it can be.
That leads to reduced venous flow. This is what is proposed. And meningitis is possibly not related to COVID-19.
Not related to COVID.
So those patients can be excluded from this study. Thank you.
So in your practice, you are seeing so much of surge, sir, in this IAH?
Not currently, but during the first and second wave, we did see a lot of patients. Neurological complications were quite common, and most common was stroke, followed by disc edema.
Okay.
Thank you.
So next, we invite Dr. Prasanna Venkatesh Ramesh. He will be presenting the keynote address for the comprehensive Neuro-Ophthalmology 3D touch interface application with augmented reality.
Hello. Yeah. Thank you for the opportunity. So, can I have my slide? Yeah. This was the paper that was presented last year in the MTC, which won the best paper award. So, for the next few minutes, I have no financial disclosure, and this is a simple basic sciences. I'm going to take you into the basic sciences of neuro-ophthalmology. So, there were many theoretical limitations of a concept. So if you take, for example, an image of a cavernous sinus, or when textbooks are referred, Even textbooks, there seems to be not really consensus about what is that you really see that is in a two-dimensional or in a three-dimensional plane, circle of Willis, or even for that matter any neuro-ophthalmic structure. So we went back to our drawing board, and you can see this is the QR code. If you have an iPhone now, you can get this app. It's a 3D animated neuro-ophthalmic imaging app. We built it on a three-dimensional interface with high-resolution real-time images with augmented reality. So I start with this video. On the left hand side you can see, as well as on your right hand side, subtractive learning. So if you see, for example, so when the skin button is chosen, you can see that the skin is subtracted, so that the power is there for the reader. So you can choose which part or which frame you really want to. So now you can see that if you want to zoom in, you use your fingers, you zoom in, and on the other side you are having the brain. So you decide which structures you want to subtract. If you want to have the nucleus, the nerve, you want to trace the course of that nerve and how it goes and finally ends into the extraocular muscle, you can actually do it. You can see that this is me. I'm pointing the arrow here. The skull, the meninges are now subtracted. I'll just forward the video now. You can see that now the transparency of the brain is reduced here. So that this is like a holistic way of learning which textbook doesn't give you. So we went to our drawing board, and you can see that you can use your zoom. And on the right hand side now the eyeball structure has come. We went to the level of up to the optic radiation and all the nuclei as well. Let me see if I can get you that slice. So even the nucleus, all the nuclei, right? You can see these are just a fast forward video of the same. And then on the other side we also used a three-dimensional smartphone simulative concept, where a neophyte who enters, you can see that if he takes his phone forward like this is just with your smartphone, you move forward. If you go into the pupil like a direct ophthalmoscopy, you can see that a fundus evaluation is done and you can just come back. So this is a spatial orientation which every one of us have in our smartphone, which is augmented reality with the current mobiles available. So we went back to it, read the anatomy, we went back to the three-dimensional software, we read the Cunningham's and Chaurasia, we created the three-dimensional because it was not easy. We had to be very foolproof because we are recreating the anatomy in a three-dimensional plane. And once it was done, we sent out a satisfaction level questionnaire through our people or the neophytes, a cross-sectional study, a comparative study on Google Form platform. Questions were pertaining to knowledge and comprehension, graphics, tutorials, innovative representation, and more of additive 3D cognitive features. And this is a questionnaire that we actually employed. And then it was sent out to mail for all the 217 ophthalmologists who actually were using it. 203 responded. This study was done last year, as you can see, from July 1 to July 7. And the satisfaction levels were graded as satisfied, neutral, or dissatisfied with and without this application. And a pair t-test was actually utilized, and it was quite statistically significant. So you can see that with this application there was not really a blind spot for the user. He was able to navigate through any part in the eye which the textbooks were not providing, especially when you read an anatomy, right? You need to really cognitively think about structures, but with this you can subtract structures that you really want only those structures to see, and then that's the edge this gave with and without this application. So this, my dear friends, seems to be a much pedagogical tool for neuro-ophthalmic learning. It helps in e-counseling. More than neuro-ophthalmology, this can be used into other specialty or other subspecialty of ophthalmology as well. So according to our knowledge, there is no application till date which uses real-time high-resolution augmented reality images with the subtractive element, where you can choose which structures you want to subtract for an interactive digital 3D ophthalmic learning. And it simplifies the concept for a immersive 3D pedagogy as well as counseling, and it is available from the App Store because Apple phones give you this LiDAR technology where we are able to crack it, and with this QR code on the top, or you can go to the App Store, type EYE space MG space MAX, you will get this application in your phone. So thank you once again AIOS for the opportunity to deliver this talk which won last year in the AIOCMTC partner. Thank you.
So I think we had wonderful presentations. Everybody made wonderful presentations and we had good learning. Hopefully we will all take home some messages from these research, and we'll try to incorporate these into our practice. Thank you everyone. I thank Dr. Murthy Garu and Dr. Ashok Vardhan for being there, and Dr. Shiv Prasad, who was also there but had to leave for the inauguration. Thank you.
So good that we had all the presenters.